Hello and welcome. My name is Tim Poe. I'm Director of Telehealth with the UNC Cancer Network here at the UNC Lineberger Comprehensive Cancer Center. A few preliminaries before we get started with our lecture. I want to let you know that if you're having any technical difficulties at all, please contact us right away at 919-445-1000. We want to, don't sit there experiencing bad audio or anything else. Call us now. Let us know. We're here for our RN and our Allied Health lecture on December 6th, 2017. This will be the last lecture in this series for the year 2017, and we're glad to have you here. We'll talk about Poll Everywhere in a moment. You can check us out on the web at unccn.org, on Facebook, on Twitter, on YouTube, lots of places to find out more about us. We'll be using Poll Everywhere for our polling today. A couple of ways you can join. If you have a browser, whether that's in a smartphone or on a computer, you can go to pollev, pollev.com/UNCCN. You'll see the questions as we go along, and you can respond there. A lot of our listeners prefer to use texting, and so you can text to the number 22333, the letters UNCCN. So to the number 22333, you'll be texting the letters UNCCN. Do that just once. You'll get a response back that says join, and you will have joined the session, and then you'll be able to respond, whether it's a letter answer or to submit a question as we go through today's presentation. Well, Dr. Asher, welcome. So glad to have you here today.
Thank you. It's a pleasure to be here.
I'm pleased to present Dr. Gary Asher, and he's the Director of Integrative Medicine Services at the UNC Lineberger Comprehensive Cancer Center. He's been a practitioner, teacher, and researcher in the field of integrative medicine for over 20 years. Dr. Asher's research focuses on the use of complementary and alternative medicine for chronic conditions such as hypertension and cancer, with a primary focus on the pharmacokinetics and pharmacodynamics of botanical agents. Almost had it.
Tongue twisters there.
They are. He has been involved in several acupuncture studies as well as systematic reviews of acupuncture for pain and non-pharmacological treatments for depression. He is currently leading clinical and translational trials of curcumin for prevention and treatment of colorectal cancer. So tell us just a little bit about your journey to integrative medicine. What led you to this interest in this career?
Yeah, so my interest dates, I think back to the 80s and early 90s, where I just had a tremendous interest in the outdoors, hiking, cycling, those sorts of things, and what was going on in the environment around. The most obvious thing for me were the plants.
Okay.
And so I had a natural inclination to try and understand a little bit more about what's out there, what are the plants, just the botany aspect of it, which then, of course, leads pretty quickly to, well, is it used for something? Is it a remedy for something? And I start to hear a whole lot about home remedies. And then the next step, as I kind of learned about that, was folks asking me, well, could I use this? How could I use that? Which really led me to today, where I really have more science-based, interest in how does this work? What does it do? How might we use these sorts of things?
Gotcha.
So a lot of that came before I went to medical school, then came medical school, and then there's kind of me now kind of trying to put those things together.
Great. And I skipped right over our poll question just to let folks know. The question was, according to 2002 estimates from the World Health Organization, what percentage of the world's population relies on alternative medicine as their primary form of health care? If you think that's 10 to 30%, give us an A, 25 to 40% a B, 50 to 60% a C, and 65 to 80% a D. So let us know. We'll give you just another minute, and thank you so much to those who've already shared their thoughts. This is anonymous, so don't worry about that. Do you think that without that interest, do you think you still would have become a physician, or was that instrumental in you becoming a physician?
I think it was instrumental in my becoming a physician. I think I had early interest in medicine, but really my interest was not in going into medicine, and it was really seeing what these things could do, but also recognize the limitations of them,
Mm-hmm.
that encouraged me to go that next step and kind of say, well, what else is there out there? What else could I be doing? How do I broaden the tool bag?
Right.
And then from there, it really became an obvious thing for me is the level of research, just asking and answering the scientific questions about these things.
Great. Well, we're glad that you did. We're glad you're here today. How are they doing? We've got low for the 10 to 30, a little higher for the 25 to 40, 50, 60 is the lion's share of our answers.
And none for the 65 to 80. This question blows my mind when I think about it, because it turns out the right answer is actually D here, and nobody put that.
Oh.
And every time I think about this question, I'm also in these lower groups. I don't expect it to be as high as that. You have to remember, around the world, there are a lot of these indigenous medicine systems. There's a lot of poverty, and it turns out that for large swaths of the world, these kinds of therapies are mainstay, whether it's part of their indigenous medicine or as home remedies or something like that, where they don't have westernized medicine or very advanced Western medicine. We see this quite a lot. So it's really, it's actually D is the correct answer.
Impressive.
Yeah.
Well, we hope you have lots of questions today. We're going to stop 3 or 4 times during the presentation to allow you to go ahead and submit your questions via poll everywhere. So we hope you'll be thinking about those and getting ready to submit those shortly. So look for those opportunities. And without further ado, the evidence base for integrative approaches to cancer care with Dr. Asher.
Great.
There you go.
Thank you.
There's the cursor. Thank you.
Thanks, everybody, for being here. Okay, so this is the cursor. We've got forward and backwards. Terrific. So as we said, there will be a couple of opportunities for quick questions if you've got them. I anticipate there'll be some time at the end for the bulk of the questions and for any discussion that we might have. And I'm just going to kind of launch right into it. In broad brushstrokes, what we're going to be covering, some terminology just to make sure that we're all on the same page about what these terms mean, what they indicate, and so we're just using some common language. There'll be a large section on CAM therapies that we'll talk about and some of the evidence about that. We'll talk about who uses CAM and why, and a couple of pieces there, and maybe how we might interact with those patients. So those are, in broad brushstrokes, the things that I'm going to cover today. So we'll start off with this definition, CAM, Complementary and Alternative Medicine. It's fairly ubiquitous, I think, now. It's kind of hard to come across somebody who hasn't heard of it. When we use the term, people use it to mean a variety of different things. Harkening back to the early 90s when this probably came out as a term to begin with, it was essentially defined as anything that wasn't taught in medical school. And this definition that we have here kind of plays off of that, right? The group of diverse medical healthcare systems, practices, products, not presently considered part of what we would say conventional medicine, what most of us are practicing today. It has 2 parts. There's the complementary part, and then there's the alternative part. We tend to focus more on the complementary piece. What can we use alongside of what we do conventionally, as opposed to the alternative part, which is what we might do instead of conventional therapy. So that's CAM.
Yeah, we can get audio. Yeah,
We've got a little audio breaking through. Good.
We have one of our sites that just unmuted, and if we could ask you to go ahead and mute, please, that would be great. Thank you so much, and if Veneranda, thank you.
There we go.
I think we're almost got that. We want to make. I'm going to turn down the volume here. Yep, sounds like that site is muted now. Thank you very much.
Right. So that's CAM. That's CAM therapies. So. Right, next comes the term integrative medicine, which is actually a different term. It includes CAM therapies, and it's an important 2-part definition. The first part, as you might expect, right, this is the combination of therapeutic approaches, includes best practices, and I would add evidence-based practices, ideally, from both conventional medicine and those CAM therapies, kind of puts them together. Right, that's the first part of this definition. The second part of it, though, it in some ways is even more important and is really what is an important piece, particularly to patients. And so this is the and here is, in addition to the physical, right, which is what we tend to focus on, attempts to address intellectual, emotional, spiritual aspects of illness, those other parts of a person that we sometimes don't address quite so well in the conventional medicine world. And so this is integrative medicine, combining these things all together. Next are the practices, and this has gone through some changes over the last couple of years. You know, on the one side we've got our splitters, and on the other side we have our lumpers. And what you see here is a bit more of a splitters definition or splitters world for what CAM practices look like, dividing it up into these 4 domains of the biologically based practices, which is largely dietary supplements and diets, the MindBody Medicine, which might be meditation, Tai Chi, yoga, things like that. Body-based practices, this is massage, chiropractic, osteopathic manipulation, energy medicine, things like Reiki, therapeutic touch, magnets, light therapy, and then we've got these cross-cutting whole medical systems. Just so that you're aware of the terminology, this has changed a bit, right? So we're more in a lumpers world here. The terms have changed a little bit to complementary health approaches. So if you're reading and you kind of go, what is that? This is sort of the new terminology for CAM. All of the dietary supplement pieces get lumped into natural products. You'll see dietary supplements and natural products used interchangeably. And then everything else gets lumped into this category of mind-body practices. And then we have the traditional medical systems, these whole systems that I'll maybe say just a word or two about later on. And lastly, kind of the topic that we're really going to be focusing on more today is integrative oncology, and that's kind of the application of integrative medicine into the field of oncology, combining both conventional and complementary health approaches together for cancer treatment, symptom management, and survivorship care. Those really are the 3 topics that we focus on.
All right. So here we have an opportunity. We'll assume that A was for the last poll, so we're sorry you didn't make it into that one. But here's an opportunity. If you have a question based on that initial discussion there, please go ahead and let us know, and we'll see that up on the screen in just a moment. So really, this complementary versus alternative could be the same therapies, but the alternative would be at the exclusion of the other.
Yeah, which is just a simple definitional thing. I think early in the field, most folks thought, well, there was conventional medicine and then this other stuff, which was really an alternative.
Right.
And there was some, separation of the 2 fields a bit. One does some crazy stuff, the other one does some crazy stuff. It's one or the other. I have a slide later on, I'll kind of point this out again. Really what happens is this overlap where folks do one, they do another, they kind of do them together. And so it's really the complementary thing. You can see it in the language, complementary health approaches. It's really the thing that we're much more focused on these days. Where do these things align and can work together?
Okay, great. Well, I'm going to assume that as we go along, I know you're going to have questions, so you can go ahead and start texting those as Dr. Asher is talking, and then we'll see those in a few minutes when we come to another Q&A slide here.
Great. So let's move along. Many of you have probably seen a slide something similar to this one. It says, lots of folks are using CAM, right? The green, so this is survey data, National Population Survey data. For those of you who are interested, in National Health Information Survey, NHIS, that this comes from. Every 5 years, they ask a lot of questions. There's a CAM supplement that asks the question, have you used any of this long list of CAM therapies in the last 12 months? In the green bar are the results from 2002 that said about 36% of adults said, yes, I use at least one of those things in the last 12 months. In 2007, it's about 38%. A few years ago, the 2012 data came out. It's really not that much different. What we see here, it's roughly a third or a little bit more than a third of the general U.S. population that says, yep, I use CAM therapy. I have used it in the last 12 months. Some folks drill down and say, well, have you used it in the last month, or how frequently do you use it? This is the general data, okay? We want to get a little bit more specific. We want to think about the cancer population. From that same database now, these are data on respondents with cancer, right? And so if you kind of look down this column here, you see 16% said, yeah, I've used some kind of whole medical system. 32% said, yeah, I use some kind of herbal therapy. Here's the percent for chiropractic and massage. And you can kind of look down the list and say, that's interesting. Doesn't look like it's a whole lot, but some of them are pretty high. for this slide, what I want you to do is compare this with, these are the respondents without cancer. Go back for a second, and I said 36 to 38% of the general population said, yep, I use one of these therapies. Well, when you compare the therapies, those without cancer and the general population to those with, what you'll see is the numbers go up. 11 to 16, 24 to 32, 64 to 76. This is pretty much true all the way down the road, right here. So the message here is that while it's popular in the general population, it's even more popular in the cancer world. When we go to specific cancer populations, to cancer hospitals, to patient populations that have cancer, we see that the numbers are actually quite a bit higher, right? 55 to 70% said, yep, I use CAM therapy after I got diagnosed. I've even used it during treatment, and this is a particular area of interest for me, where folks are using dietary supplements, for example, along with chemotherapies or radiation. I'm particularly interested to look at where the interactions there, where there might be benefit, but also where there might be harm. Here are some data. So these are data from our cancer center. These are data that I collected. I'll take you through this whole slide because I understand it's a little busy, but we're going to go through it step by step. So these were patients that we surveyed at the North Carolina Cancer Hospital. They had all received treatment for some cancer treatment between 2010 and 2012. And what we did actually is we started in 2012 and we worked backwards until we got the number of folks that we were looking for. All of these folks had either breast cancer, prostate cancer, lung cancer, or colorectal cancer, so largely the four major ones. We asked them a whole bunch of questions about CAM therapies. Did you use this? What did you use? How did you use it? And then we also asked, when did you use it? And so you'll notice down here, for example, did you use it before you received your diagnosis? Did you use it during your primary active treatment? We define that as surgery, chemotherapy, radiation, kind of that first go at therapy of some sort. And did you use it sometime during survivorship? Okay, we divided this into four categories. I was a splitter at the time, so you can see the MindBody Medicine group here, the Dietary Supplements here, the body-based therapies here, and the energy medicine down here. And then we separated things out. We have a blue line in each one of these that kind of says, here is the summary for this whole category. And then down below, you can kind of see here are the different therapies that we asked about. So kind of going through one of these, you'd say, about a third of folks said they were using some kind of mind-body medicine before they ever were diagnosed with cancer. Dipped just a little bit during treatment, and it kind of rose back to those same levels when they went back after treatment, right? And among those therapies, we asked about deep breathing exercises, Tai Chi and yoga. Meditation, I think, is a little bit hard to see. It's the purple line. Here's acupuncture down at the bottom, right? And so that's at our cancer hospital. That's the kind of use that we saw for mind-body medicine. Kind of flipping over here to dietary supplements, we see, wow, there's a lot of uptake here. 70% before, 60% during, 70% before. A lot of it is vitamins and minerals. We might not be surprised. But, between 25 and 30% of that are herbal supplements, the kinds of things that I'm concerned about interacting with medications, for example. Right? If you step back and kind of look at all four of these, you'll notice a trend, right? There's kind of this V shape here in almost all of these graphs, right? That says folks started at a baseline rate. During treatment, they maybe dropped off a little bit, and then once treatment was done, they kind of returned to some baseline. There's two exceptions here. One is this green line down here, which is chiropractic. This was kind of interest to us. We sort of wondered aloud, why did that one alone not kind of rise up to baseline? The assumption that we made here, we didn't confirm this, was that there were probably some folks who were using chiropractic as their primary care. They developed cancer, and they maybe didn't think it was appropriate to go back to their chiropractor for care after that, and so that may be why that one jumps off. So it sort of stands out there. The other one here is this inverse V. It's this red line. It's mostly driven by this red line, which is prayer, and it probably doesn't require much explanation to say that prayer goes up after diagnosis while you're in the treatment phase. But really, these are fairly close to flat lines. So this is what we saw in our cancer hospital. It's really not a whole lot different from what other cancer hospitals have reported or other cancer systems have reported in terms of patient uptake. One of the other takeaways here is, there are a lot of folks using CAM therapies in this cancer population, and I think that's what these numbers support. So why? So a lot of folks use CAM. Why did they use CAM treatments? I kind of alluded to this a little bit earlier. There's probably two important things to take away here. First, right? Hey, this is from a patient perspective. CAM therapies plus conventional therapies together are superior to one or the other alone, right? This is an important lesson that we've learned by talking to patients. They're looking for the best of both worlds, right? And so this is among CAM users in the oncology world. 80% of the CAM users says, here's the reason why. This is really important to me. There's a second thing that comes up when we ask this question as well, and this kind of harkens back to where I talked about that definition of integrative medicine. There was part one, which was CAM and conventional therapies together, and then part two, which was think about me, the whole me as a person. And that's what this one kind of speaks to. The health of my body, mind, and spirit are related. Right? It's a patient belief. And whoever cares for my health, please take that into account. Patients really value that. This is important to them. And to some extent, this is one of the reasons why they look towards CAM therapies and what they're expecting from us as providers. Why do additional reasons CAM gets used among cancer patients when you ask them? Probably the most common one here at the top, right? They're looking for therapeutic response, either in one of two areas, right? They're looking for better response to treatment, no surprise there. They're also looking for improved quality of life. Reduce my nausea. Do I get better sleep? Do I feel better on average? Can you reduce some of the symptom relief is sometimes what a lot of this comes down to. In the next group of responses here, this is probably not a surprise to anybody in the cancer world. There's this tremendous loss of control when you get really diagnosis of any chronic disease. Cancer sort of sits at the top. You enter into the system, you give away a lot of your self-control, and that's particularly troubling for a lot of people. They actually, one reason why they'll use CAM therapies, they can make some decisions on their own that they feel they're in control of, and that may explain some of their use. There's also, at least among a smaller population of folks, strong belief in CAM that they come to our medical centers with at baseline. And it turns out that this one here probably drives a lot of the referrals that I get for the consults that I do, because providers can easily see, here's somebody who it's clearly important to, and I want them to speak with somebody who has a little bit more knowledge than I do. Kind of down at the bottom, we've all seen this as well. Folks who are looking for hope or a last resort. They've maybe had several treatment failures. When I see these folks, sometimes these are some of the most difficult consultations that I have, because they really are looking for, what do I have to offer for treatment now that I've been through the rest of the system? And often what I have to tell them is, in terms of primary treatment, there's not a whole lot here, and that can be difficult. Down here at the bottom, this is just really more of an assumption that I want to dispel, because it's really not a driver for CAM use. I think historically folks thought, the reason folks go to seek alternative treatments is because they're really unhappy with what they're getting from their conventional providers. And it turns out when you ask patients, there is a small group, and when it happens, we probably remember it a little bit more than some other memories. But really, this is not the majority of these folks. This is really a small driver for CAM use. Right. So that's who's using. What are they using? This kind of goes back. This slide goes back to those national data. This is population-based data, although it really isn't that much different for the oncology population. We see at the very top here, natural products is far and away the largest category for what folks are using in terms of the CAM therapies. We can see a lot of the mind-body modalities like deep breathing, Tai Chi, yoga, meditation, progressive relaxation, guided imagery down here, and then the body-based therapies like chiropractic and massage therapy are all here. Again, this is the general population, but when we ask, cancer patients what they're using, it really looks very much similar to this. Now we've got to think about, well, folks are using these things. How are they paying for them, right? Insurance companies, they're not forking over lots of dollars for this. Do patients really do this? Like, where does the money come from? And so, this graph here on your left, I guess, right? This is a comparison of out-of-pocket spending, right? This is not what your insurance company pays for. This is what you fork over at the end for prescription drugs at the end of a year, right? So this is U.S. population over 1 year forks over $54 billion out of pocket on prescription drugs and almost $13 billion on natural products, dietary supplements, right? This is not a small amount of money, right? And it's all out of pocket. Again, we go to physician visits. This is the out-of-pocket expenses here. So this is your, help me remember this, your copay, your co-insurance, your deductible, I don't know, whatever else the insurance companies will get out of your pocket. This is all that stuff that comes out of your pocket. $50 billion on doctor visits, right? $15 billion on CAM provider visits. Chiropractors, naturopathic physicians, homeopaths, massage, all of that. That's here. Folks are still forking out reasonable dollars for this, right? Which really begs the question then, well, who, right? Everybody thinks, well, my patient really can't afford this. They're not going to be able to pay for this. To a certain extent, that's true. But this next slide this one always surprises me as well. Here we have, again, national data on who's spending out-of-pocket dollars on CAM therapies, right? And we look at levels of income. Under $25,000 family income, 25 to 50, 50 to 100, and over 100. This is the yearly average expenditure, $435 for an individual, up to $590. And what I point out here is, while there's a gradient, which you'd expect, the more money that you have, the more you spend, the difference between the lowest and the highest bracket here isn't all that much. Folks are still forking out dollars for this regardless of their income. So if you think that, I'm not going to talk about this with a patient because they're low income, they're on our charity care program, for example, think again, at least in terms of having a conversation with them, because depending on where their values lie, there are a lot of these folks who are still willing to fork out some dollars for this. Right, okay, so natural break. Any questions that we might have here?
And while we wait for this, I think that's fascinating, the relationship with the finances. I mean, I could even, looking at that graph with the chiropractic, I could speculate, well, since chiropractic often is covered with the health insurance, could you see a great deal of use, especially when you've met your max on your deductible and you say, well, I can go to the chiropractor again and again and again at that point without incurring additional out-of-pocket costs. At the end of treatment, you may be very depleted, and we've had other discussions here about financial toxicity associated with cancer treatment, and you may be in a position where there's not a lot of money left once it's coming out of pocket again.
Yeah, there are a variety.
And that's clearly speculation, but it would be interesting to understand all of this even better.
There are a variety of factors that go into this. Which insurance plans cover which services, and there's this cutoff between private insurance and Medicare. Medicare doesn't recognize any of these. So
interesting.
Yeah, so anybody who has a third-party policy, to cover after their Medicare, Medicare won't pass the bill through.
Okay.
So even if they have a policy that covers it, they won't get it covered, and so that becomes an out-of-pocket expenditure too for a vulnerable population who's often on fixed income.
Yeah, so lots of different scenarios that can play into these figures. And we do have a question: is it safe for a patient receiving chemotherapy to get acupuncture?
It's a terrific question about the general safety of acupuncture in general. And there are actually some pretty good studies about acupuncture safety. They largely come out of Germany, where they have hundreds of thousands of patients who've been treated for, pain and headache pain, back pain, joint pain, migraine, where in general acupuncture is pretty safe. A long time ago, when folks were not using, today they use, single-use sterile needles. There was a time when folks were sterilizing their own needles and reusing them, and sometimes the sterilization wasn't so good, and there was some infectious disease transmission that way. We almost never see that. Today, I think that really the issue with acupuncture, we think about with patients with neutropenia who might be at higher risk for infection. We can use infection precautions. We can use sterile swabs at the acupuncture site. The needles actually are sterile to begin with. We can use sterile technique, although folks who are severely neutropenic will often recommend not. For general patients who are otherwise in general good health, using acupuncture during chemotherapy it should be fine in most cases. In those cases where we're unsure, we will sometimes use acupressure instead of acupuncture, so there's no needle puncture of the skin, but we might actually stimulate points, even just with fingers like this for nausea, for example.
Gotcha.
So it's a great question. We do recommend this all the time for folks during active treatment. It's actually one of my go-to things during active treatment where I'm more concerned about dietary supplements and supplement drug interactions. Here, there's actually a fairly good safety profile.
Okay, thank you. I'm going to try and get in one more briefly here. So when Dr. Bosch was here talking about patient-reported outcomes, we briefly discussed the notion that with certain symptoms, patients might be reluctant to actually share those because of some sort of investment in the physician's success. Is there any sort of similar dynamic here where CAM use may be underreported because the patient's very life is at stake here, and might she or he be uncomfortable sharing certain CAM therapies because again of that investment in the success of the physician and ultimately their own life?
That's a terrific question, and actually have a section towards the end where we'll get to it on disclosure. The short answer is there are a variety of reasons patients don't talk about this with their providers, and I will actually get into it.
Perfect.
And that's one of them.
Perfect.
Yeah,
okay.
absolutely.
Well, let's move on. Keep those questions coming. We'll have more opportunities as we go along.
Great. All right. So into the belly of the beast here, the heart of the matter. This is just a summary slide here. I just kind of want to point out to everybody, particularly if you're interested, this is all the small print down here, but this is actually some pretty good information. These are 3 evidence-based guidelines on CAM therapies in cancer populations, right? So this one done by Heather Greenlee is in breast cancer patients. This updated one in chest by Gary Deng is for lung cancer, and then there's this one down at the bottom from the Society of Integrative Oncology. There's that term again, which is more of a general, for all kinds of cancer patients. Summarizing them very briefly, there are evidence-based recommendations for many mind-body therapies, for massage, exercise therapies, acupuncture, supplements, and so on. And they say things like, don't massage deeply at, sites where there was a recent surgery or where, there's a large tumor burden, for example. Things that we probably know intuitively, but now we have some evidence to say, this is a bad idea. Recognizes support groups, cognitive behavioral therapy may be helpful for these kinds of things in cancer patients. Acupuncture is particularly good for pain and nausea, vomiting. There are certain other mind-body therapies that may be good for anxiety and pain and mood disorders. And it actually recommends against dietary supplements for treatment or prevention, disease recurrence in these populations as well. There's actually quite a few of these. We're not going to get through all of them, but I'm just going to kind of pick and choose just a few of them to talk about in the next few slides. But if you're really interested in this, the place to go are these 3 guidelines. Right, so kind of going by the 4 categories that I mentioned earlier, we'll start with the dietary supplements. And right, so I mentioned earlier, this is a large group of different therapies. There are the botanicals, all that stuff that I was interested when I would go for walks in the forest and see the green leafy plants and pull them up and go, is this tasty and safe and all that sort of stuff. And a lot of folks still do. The vitamins and minerals that we're all familiar with. There's this 3rd class, though, that I just want to point out here because it just doesn't fit in neatly here, right? Probiotics, what is that? That's not a plant. These are bacteria, right? How did that get in here? It falls into the category, just not neatly. Things like dietary oils, fish oil, omega-3 fatty acids, evening primrose oil. CoQ10 is an enzyme. I don't have a picture of it here, but melatonin is a common one in this population. This is a neurotransmitter that's naturally secreted by people. All of these things fall within the natural product or dietary supplement category. There aren't very many of these that I recommend in practice, particularly during acute treatment. I'm going to just back up for a second. My general approach with these is folks will actually ask me more about, I'm taking this. Is this a good idea, a bad idea, or neutral? They'll often come with a bag full of stuff. It's one of the type of consultations that I'll do. And we may go through there and look at the medications that they're taking and the supplements they're taking and talk about interaction. Then we may talk about efficacy. How well does this work for that? Pomegranate juice for prostate cancer, for example, is a common one that comes up. And the evidence is so not strong enough for me to say everybody who's got prostate cancer ought to be taking lycopene and pomegranate. I just think it's not there yet. But on the other hand, if there's not demonstratable harms, I can still support somebody who's interested in doing that. And that's often the format of the conversations that we'll have. We'll weigh the benefits, which may be unknown, the harms, which may be known or unknown, and then try and come up with a rational way of picking through and saying yay or nay to different combinations that folks are using. But I don't, with a few exceptions, I don't typically recommend these. The few that I do, there's pretty good evidence for ginger and chemotherapy-associated nausea. We know the constituents, we know the pathways. This is a similar pathway to the way Zofran works, which we're all familiar with. There's reasonably good evidence for nausea and vomiting from a variety of reasons, but the one we're most interested here is chemotherapy induced. We know that while the fresh ginger tastes nice in tea, these constituents really are generated when the ginger root gets dried. So we recommend dried ginger root capsules, which are terrible tasting. Don't make them as tea, but take it as a capsule, and it can work really well. How might we recommend folks take this? This may be the first thing that they want to try before they go to their Zofran or their Phenergan or their Compazine. Really depends on the patient and the relationship they have both with you and their treating providers. There's not too much that we're concerned about in terms of the safety. You'll read a whole lot about theoretical bleeding, and that comes from this platelet inhibition thing. It turns out that clinically we don't see this. It's a theoretical concern, and for somebody who may be on antiplatelet or anticoagulant medications, we might have a slightly heightened sense of be cautious with this. But for most other folks, we really do not see this. The other one that I talk about is ginseng, and I need to say a few words about ginseng because there's lots of different ginseng out there. There's the American variety, there are these Asian varieties, then there are these non-ginseng ginsengs like I have up here, Siberian ginseng, which is actually a different plant. When I talk about this, I'm talking about the American species, and the reason I'm talking about that largely comes down to safety. A lot of the bad rap that ginseng has for herb-drug interactions or just interactions on its own come from the Asian varieties, and so to keep it safe, I tend to recommend the American ones. There are a couple of studies, this being one of them, for American ginseng and cancer-related fatigue. This isn't the most fantastic done study around, but it's reasonable evidence that this may be helpful in folks with chemotherapy-induced or associated fatigue. Given that we have very little to offer these folks, this is something that I can speak about, and that we can at least give a therapeutic trial, particularly during treatment. MindBody Medicine, I'll just say a little bit here. This is one of the largest groups. It includes a whole bunch of movement type, or physical activity type things like yoga, tai chi, qigong is also in there, progressive relaxation. There are a lot more of these mindfulness type things, meditation, hypnosis, biofeedback, and guided imagery. There are things like support groups and cognitive behavioral therapy. There's a mixed body of evidence about how well these things work for a variety of different conditions. I'd say probably the strongest evidence for a number of these is in helping with anxiety, chronic pain, mood, particularly quality of life issues, and maybe some for sleep. Just to highlight one of them, here's some information on yoga, for example. And this slide always surprises me that, almost 10% of U.S. adults say they practice yoga. To me, that seems like a lot. I'm surprised to hear that in the United States. I'm heartened to hear it. And it's driving a whole bunch of research in how yoga might benefit, how yoga changes genetics and epigenetics internally and protein production and disease processes, as well as outcomes. How do folks do better with their sleep or with other things? Noted here, folks who are yoga users tend to be motivated to exercise more regularly. They eat better. They report improved sleep, reduced stress. They cut back on alcohol and cigarette smoking as well. So there are these strong associations. Here, in the text here, we have a really nice Cochrane systematic review of about 24 randomized controlled trials that says there's reasonable evidence that yoga can improve the quality of life, reduce fatigue, and sleep disturbances. This is in cancer patients, right? It can reduce depression and anxiety and fatigue, especially compared with some of the other interventions that we have. So fairly low intensity to do it. It's one of the things that we've chosen to focus on here at the Cancer Hospital in terms of offering it to cancer patients for these reasons. Body-based therapies like massage therapy, lymphedema therapy, chiropractic. There's some information on these. I'm sure you're all familiar with lymphedema therapy, particularly in the post-surgical breast cancer patient. You may not have heard quite as much about something called manual lymphatic drainage, which is a massage therapy technique that mimics lymphedema therapy, and there's some evidence that it may be as beneficial after somebody has completed lymphedema therapy. We use massage therapy here in our hospital on the inpatient side, particularly for folks who are here for more than a few days, really for these kinds of things, for helping with acute pain, helping with anxiety, helping them to feel a little bit more settled, and really humanizing them while they're in here during their hospital experience. We've also, for brief periods, had a massage therapist doing hand and foot massage in our chemotherapy infusion center as well. And then there's the energy therapies. These are like massage therapies, although they tend to be a little bit more lighter touch. And we see the same kinds of things with stress reduction and enhanced quality of life. They're low cost to do. The impact can be moderate to even high depending on the patient population. They're fairly simple to do, and as you can kind of see from the photos, very low in terms of invasiveness and easy to do in pretty much any clinical setting. Acupuncture is one that, there was a good question earlier about its safety. It gets talked about a lot. If you remember back to the slides where I presented the data from our hospital, in terms of how much it's used, it was kind of at the bottom there. It's less than 10% of folks. So I'd say that it's probably underutilized. It has fairly good evidence in general for pain of all types, and we know that acupuncture stimulation stimulates the body's natural endorphins and enkephalins, our own pain-mediating substances. So it can help particularly that way. There's fairly good evidence for it in mediating nausea and vomiting. So I often recommend it for folks who are struggling with that. It's very nice in that, right, there's not a pharmacologic action here, so we're not worried too much about that herb-drug interaction kind of thing. It may have a role in xerostomia, and we've actually put an acupuncturist in our radiation oncology suite to work with the head and neck cancer patients for whom this is a really terrible problem. And then the data on fatigue and neuropathy and hot flashes is sort of plus or minus. I think it's reasonable to consider where we don't have other therapies available. We might use these things. Here, just a representative study in a cancer population. This is a nice randomized controlled trial published now a number of years ago in the JCO. These were women with early stage breast cancer on aromatase inhibitors, and as we all know, those women are highly susceptible to having all kinds of aches and pains, particularly joint pain. And this was a study of aromatase inhibitor-induced arthralgia, showing that there was significant improvement in joint pain and stiffness with acupuncture. So reasonable therapy to consider, I think. Lastly are these traditional medical systems, and they are really systems, and so they combine many of the therapies that I've kind of briefly touched on previously. Ayurvedic medicine is one of a number of traditional medicines from India. Traditional Chinese medicine, I think, is probably the one most folks have heard of. This is one of, again, a variety of traditional medicines from China. Homeopathy and naturopathy are a little more Western. They come largely out of European origins, and there are many, many more than just these.
All right, and we have more questions. Thank you all for sending those in. So can you say a few words about cancer diets, carbohydrate restriction, anti-inflammatory, Gerson, etc.?
Yeah, a few words. This comes up almost with every patient that I speak with. What's the best diet? And this can be a tough question to answer. I think carbohydrate restriction, that's a nice way of saying that, folks come to me and they say, is sugar bad? And this is a real problematic conversation for me because I know you can cut sugar all the way out of your diet and go to a ketogenic diet. And we do recommend that in some cases for weight loss, but we know what happens is the body then creates its own other sources of energy that, again, feed all the cells. You can't cut carbohydrates out, and you probably shouldn't. Yes, we know that cancer cells feed off of glucose, and if we kind of cut that off, maybe they won't grow as much, but so do brain cells, and so do the other cells of the body. And so, at least for the time being, we don't know that this is really beneficial. There are some interesting studies that look at the timing of different types of diets. And so, for example, fasting before chemotherapy infusion may be beneficial for reasons like that. But in general, going on a ketogenic diet or a low glucose diet is probably not feasible or reasonable. I think one of the most important lessons we've learned about diets, and this is really from the obesity world, is you have to choose a diet that somebody can stick with, otherwise it just simply doesn't work. And these are largely diets that folks can't stick with. Gotcha. We do recommend away from the large sugary drinks and the simple sugars, the candy bars, the concentrated glucose infusions, so to speak. But beyond that, I don't typically recommend that folks, follow this in a strong way. Okay. There's a whole lecture that we could talk about for all the other different things about diets, but we won't have time to get to the end if we go down that path.
Well, we have to bring you back. See?
Yeah.
There we go. Good. One more question here before we move on. A lot of supplements are not regulated by the FDA. Is there a brand you recommend?
So that's two questions. So let's even step back just a little bit about what's the regulatory environment here. So Dietary Supplement Health and Education Act, DSHEA, this is out in the early mid-90s, something like that. And so actually anything that's sold as a dietary supplement does actually fall under the auspices of the FDA. So they are in theory regulated, but perhaps what this question is saying is, the FDA doesn't do a very good job of it. So, given that there's not a lot of oversight, which is true, there are good manufacturing practices that are now required of anybody that is producing and selling supplements, so that's out there, but the policing of it, you're correct, is probably not terrific. How do you navigate what might be a good brand or a good product? One of the things that I recommend for folks with dietary supplements is to look for ones that are standardized. We call them standardized extracts. Usually means that somebody in a laboratory has measured that some particular constituent or group of constituents in that extract are actually in there at a particular concentration. And so while it's not a perfect sign that you've got a high-quality extract, it's a marker, I think, of high-quality extracts. You can also look to the bottles for extracts that are, produced with good manufacturing processes and under, following these guidelines. I think the last thing that you can do is you can go to a site like labdoor.com that actually independently takes bottles off the shelf and tests them to see, is what the company says is in there is actually in there. And these are freely available. They actually rate, they'll rate them, this one was the closest and this one was a little bit less and this one's a little bit less. And they'll go a second step and they'll do for your dollar, which one gets you the best product. And they do that for a variety of products. So I think that's actually a reasonable third-party place to kind of look for higher quality products.
Great. We have another great question. I think we should probably move on because I want to make sure that for anyone who needs to leave right at 1, we get to the rest of your lecture, and then we'll pick up as many questions as we have time for.
Right. So in the last few minutes, I have a couple of slides. This was a question that you brought up earlier about disclosure, right? Hear no evil, see no evil, speak no evil. Right. In terms of disclosure, I use some kind of CAM therapy, and do I tell my provider? Among CAM therapy users in the general population, it's about a third. And we've measured this now for 20 or 30 years. It really hasn't changed. And this is in the general practice environment. Fortunately, you can take a little bit of heart, and folks who have chronic disease and particularly cancer, they're reporting to some providers probably higher, 50 to 60%. But I'd highlight here that's still about half of the folks who are not really saying anything about it. Right? So it's not a small group of folks. And as I pointed out earlier, these are folks who are undergoing treatment with drugs. Many of them are using dietary supplements. The opportunity for interaction here is pretty high. So that's one concern that I have. When we ask folks, this is the question that you got to, why don't you talk about this? Here's what we find out. Number one, far and away, right here, right? This is fixable. My doctor never asked, or I didn't think it was important for my doctor to know, right? And the way these studies were set up, it was doctor, but really this could be any healthcare practitioner, whether it's a tech or the nurse or an APP or an MD, whoever the folks in the medical system are asking, getting this point across. Did we ask? Did we let them know that we think this is important? This should be easy, right? Some folks thought, boy, this is none of their business. This is my private life. Thinking about that, I'm in control of my thing a little bit. There's that. My doctor might not understand, a little bit surprising, or they might even disapprove or discourage me. These are ranked in order of how common we see them. So this is less common, but still there. This even happens. We see this a little bit more. My doctor might not continue as my provider. We do see this a little bit in the cancer world. We also see it in the pediatric world. You might, this is where, I don't want my child to have immunizations, for example. Well, then I can't be your child's provider. We have reports of things like that, but it also happens in the cancer world. Right, so these are reasons that folks say, that they don't talk about this. We have talked to patients to kind of say, well, what would they like from their providers? And there's really 3 things to take away from these conversations. The first is we should be the first ones to initiate the conversation. We have to ask them. And that should be pretty obvious from the last slide. The second is, this really should be self-explanatory too, but it should go without saying, but it needs to be said. We should be accepting and not judgmental about their CAM use. They expect that of us. And I know that can be challenging, particularly if we have beliefs, that CAM therapies just don't work, or they're a bad idea, or whatever it is. We have to be careful not to let that come through in our listening to patients. The last one, I think, is really, it kind of lets us off the hook. So I think this is important. They get that we're not the experts in CAM therapies. So even though they want to talk about it, they don't expect that we're going to give them all the answers. But what this does do is allows you to kind of find out, well, what are they doing? Enhance that therapeutic alliance with patients, and maybe where it's necessary, refer them to somebody like myself or somebody else that can actually speak with them in more detail. So, these are probably the three important things to keep in mind in talking about CAM therapy with patients. So to kind of wrap it up, bottom line, lots of folks are using CAM therapies. Several of them have fairly good evidence among cancer survivors, and there are many folks who are willing to pay out of pocket for these things. What I probably didn't put in there is that we probably need to take the initiative to be talking with patients about them and find out more about what they're doing. So I think here's a couple of resources for you. If folks want to look into this a little bit more. There are some references I think I have in the slides as well for other information. And then I think with that, this is just a little bit of information you can keep with you. This is our integrative medicine services here at our cancer hospital and my consultations. And I think with that, that's what I have. We have a few minutes.
Right, we do. Questions. Thank you so much. So that question that we'd seen earlier, is there evidence-based treatment and or a supplement for chemobrain and fatigue? So
right, two questions: chemobrain and fatigue. We often see them together. There happens to be a pretty bright guy now here at UNC who's looking at exercise and mindful type exercise for the cognitive pieces that go along with chemotherapy. So does exercise help? Which it looks like there's probably some evidence that it may. Exercise. If you could put exercise into a pill, that would be probably the best medicine for so many things. But for chemobrain, perhaps that's one. And then there are these, mindful things like mindful type movements like Tai Chi, yoga, things like that. For fatigue, there's not a whole lot out there. We do recommend exercise for that as well, and as I mentioned earlier, there's the American Ginseng may be related as well for reasonable evidence for cancer-related fatigue. Worth a try.
Great, and I would recommend, if you're interested in this topic, we have some earlier presentations in our library on chemobrain, and then also Dr. Bottiglini talking about fitness and the role of fitness in cancer treatment and recovery. So, one last question: is there a resource you recommend for vetting potential supplement chemotherapy interactions? Yeah,
there are several. Probably the two that I would recommend. There's one available online, I believe it's for free, out of Memorial Sloan Kettering called About Herbs. And this has evidence-based reviews on many of the dietary supplements that cancer patients will use. And it will talk about potential interactions with them as well. It has an app that's available. There's also a website, which I think is a little bit easier to use. So that's one source. The second, for those of us in our system here, there's something called the Natural Medicines Database. And that's available through our Health Sciences Library. It's one of the databases you can go to, and it includes not only dietary supplements, but other types of therapies as well, indications for them. For the dietary supplements, it really has extensive monographs and references out, that link out to PubMed, so you could actually read about the potential interactions. It has an interaction checker that you can put in there as well. What I would say about both of these references, they tend to be conservative. And this is a little bit more of a comment about clinical pharmacology and herb-drug interactions. We're kind of entering a period in herb-drug interactions where we had a lot of potential interactions, things that we thought might be problematic because we, in a laboratory environment, took an herb and we took a bunch of drugs and we put them together and said, it looks like this is possible. And we sort of said, wow, there's a lot of potential for interaction here. We're kind of moving into an era now where we have early clinical trials where we actually say, okay, where there was that potential interaction, we give it to a population of folks on these drugs. Do we actually see the real interaction? And in many cases, we don't.
Interesting.
So there's this translation of what happens in the lab to what happens in clinic that there's not a perfect correlation there. And so many of these databases will be loaded with potential interactions, and it's your job to say, well, is that a real one or not? Which can be difficult if you don't have this sufficient training and understanding in the field. At the very least, these databases will give you that sense that, well, maybe there's an interaction here, and then depending on the risk-benefit, we might say, well, that may not be, where we don't know for sure, that may be worth shying away from. They're now starting to get populated with these clinical trials that say, even though there's a lab interaction, there's not a real interaction, this may be okay. But sometimes it's beneficial to talk to a pharmacist or a clinical pharmacologist if you have a patient in particular that's like, well, I don't care what you say, I'm going to do this anyway. which I see a lot of those folks. There are ways to negotiate with those patients about particular combinations that have the highest potential for interaction. And that's what I do constantly in my clinic.
And it sounds like this is one where we really need to stay tuned. If I had to guess, I would guess that curcumin, which was mentioned in your bio, is one of those there where the evidence continues to evolve.
Curcumin, green tea, silymarin, I mean, all of these ones that are very, echinacea, golden seal, these ones that are really out there quite a lot. Yeah.
I'm sorry that we're out of time, but we really are. So this has been a great discussion, terrific questions. So glad to have our audience here. If you want to see this again, if you want to recommend this to a friend or colleague, please go to our new learning portal, UNC Cancer Network Learning Portal at learn.unccn.org. You can go ahead and sign up there, watch this presentation as a recording, answer some questions, and get a certificate that is relevant for you depending on your background. We have both the ASRT and CNE certificates available for today's discussion. So please go there. We also have lots of other presentations and we'll be adding more every month. So that's learn.unccn.org, free and open access to 4 credit oncology courses based on recordings of our live telehealth lectures, anytime access to earn certificates of credit from all UNC Cancer Network activities, and new live lecture evaluation process. So that's all in place, just released in November. You've been asking for this, it's there now. New process for completing the lecture evaluation and receiving credit. Just to remind you, the evaluation and opportunity to claim credit for participation for the live lecture will remain open for 7 days. Participants are designated designated UNC Cancer Network viewing sites. See your site coordinator for instructions. GoToWebinar participants will receive an email 1 hour after the conclusion of the lecture that contains information and a link to step-by-step instructions for completing the evaluation and claiming the certificate of credit for this live lecture. So please stop by the new learning portal. If you have questions or run into problems, unccn@unc.edu or 919-445-1000. All right, we want to thank the generous support of the North Carolina General Assembly for the University Cancer Research Fund and the UNC Lineberger Comprehensive Cancer Center. We also want to thank Mary King, Veneranda Obore, and Alan Brown for their critical activities in making this and every lecture possible. Coming up, special lecture that we have, a special event, Oral Cancer, a Comprehensive Overview, December 8th, that's this Friday from 12 to 1. This will include CNE, CME, ASRT, and ADA, CERP, Dental Continuing Education Credit. Please spread the word on this lecture. It's going to be a good one. All right, other lectures. December 13th, our Med-Surg lecture on metastatic breast cancer with Dr. Claire Dees. On December 15th, our community lunch and learn on lung cancer with Dr. Rivera. And on January 10th, our next RN and Allied Healthcare lecture, and that's on 5FU toxicities and strategies for management, and that's with Dr. Faso. So we hope you'll join us for all of those. Please spread the word. unccn.org. You can find information about all upcoming events, recordings of all past events, lots of other information as well. Thank you so much for being here today, and until next time.